Then I'll request.
Is that fine?
Yes, sir. Thank you. Yes, the audience have started to join. Good evening, everyone, and welcome to this webinar, After Office Hours, a discourse on ambulatory blood pressure monitoring by Dr. Shehan Silva. Very interestingly, the topic we have chosen correlates very well with the topic that was provided by Dr. Shehan Silva, After Office Hours. In fact, ABPM is an activity or a diagnostic tool that is used usually for detecting BP outside the office. So very interestingly, the topic was coined, and this very important patient-centric initiative, that is ambulatory blood pressure monitoring, is what we will be discussing today. And we have with us Dr. Shehan Silva, who has graciously agreed to deliver a discourse on this topic. So I welcome Dr. Shehan Silva, and I also welcome all the members in the audience who have spared their valuable time to join us for this webinar. Let me take a moment to introduce Dr. Shehan Silva to the audience. Not that he needs an introduction in Sri Lanka, but Dr. Shehan Silva is a senior lecturer in medicine at the University of Sri Jayawardenepura and consultant physician at Colombo South Teaching Hospital. Dr. Silva is a fellow of the Royal College of Physicians, both London and Edinburgh, and a member of the Royal College of Physicians for Diabetes and Endocrinology, as well as Geriatrics. Dr. Silva holds a diploma in medical practice from the London School of Medical Practice and integrated foundations of medical education, as well as an associate fellowship for advances in higher education from the UK. Dr. Silva, I once again thank you for agreeing to deliver this webinar. And with this, I'll hand over the session to you for a discourse on ambulatory blood pressure monitoring.
Good evening to all of you. I hope you can hear me.
Yes, sir, we can.
Yeah. Thank you, Dr. Gandhi, for that kind introduction. Dr. Gandhi and his team has been no strangers to us. Thank you for inviting me to deliver this talk on September 29th, today being the World Heart Day. And it's a privilege again to talk something about blood pressure and management of our patients with regards to hypertension, which is an important disease and a risk factor in creating other diseases. So our talk today is themed after office hours. And as Dr. Gandhi mentioned, it's on ambulatory blood pressure monitoring. So we see our patients day in and day night, and even in the evenings, and then the patient goes home. We close our office, we close the shop, and that's when the patient becomes his normal being. The patient becomes a normal person and behaves the rest of the 24 hours. And this is the time that the patient lives his or her own life. And it may be not so that we see only just a glimpse of the patient within that few minutes, maybe a couple of minutes, maybe 15 minutes, maybe half an hour, but we don't see the rest of the patient. So I start off by talking about this World Heart Day. We talk about the physical heart, but we also have to talk about the deeper heart that we have, and that is about caring and being a human. And I remind ourselves with Francis Peabody's famous words, one of the essential qualities of a clinician is in the interest of humanity, the human race. And the secret in the care of the patient is caring for the patient. The secret in the caring of the patient is caring for the patient. So I begin by bringing two cases, some cases that we come across most of our time that have had two untimely, unfortunate outcomes. So Mr. A, who is a 40-year-old male, he has come to the clinic and he has been diagnosed of being hypertensive. The reason being he has been having more than 150/90 at clinic visits always. So the office blood pressure readings have been raised. So he has been commenced on medication, and every time he takes medication, he feels that he is dizzy and faintish. This has been going on every time when the patient has been taking medication. The patient has mentioned this to the clinician, but the clinician has just kept a deaf ear, thinking that this is just an instantaneous thing, maybe a common occurrence with any antihypertensive medication. Unfortunately, the patient developed an ischemic stroke and patient succumbed. So when the postmortem was done, there was no evidence of any target organ damage. What do you mean by target organ damage? So target organ damages are outcomes that blood pressure causes upon the peripheral organs, mainly the brain, the heart, the kidneys, and even the eyes. So in the heart, it may lead into hypertensive heart disease where there can be dilated cardiomyopathy, there can be ischemic heart disease. In the kidneys, it may be chronic kidney disease. In the brain, it may be chronic ischemic changes, microvascular changes that may be there, or even dementia, which we attribute as vascular dementia. And in the eyes, as we ought to do it, we have forgotten being COVID times. We need to check on our patients' fundus, the eyes. So all of these are target organ damages. So the patient did not have any evidence of target organ damage. So ultimately, what was deemed was that this patient may have had white coat hypertension. Patient has been having normal blood pressure always. Patient has been developing symptoms of low blood pressure, and patient has had a ischemic stroke and died. We attribute it to white coat hypertension. We have another patient, Mr. B, who was 55 years of age, male, coming to a physician because he was complaining of severe headache. So the doctor has asked about red signs of headache. I won't go into details about red signs of headaches, and they were absent. The doctor did not see any abnormality in the cardiovascular examination, including the blood pressure. And the patient has been just given analgesics or anti-migrainous drugs. So patient has been managed as a normal or a simple headache. Unfortunately, again, the patient had a fatal hemorrhagic stroke and then died. The postmortem now reveals that there is evidence of persistent hypertension. So what was this? This is masked hypertension. The hypertension has been kept obscure. So we'll talk about these as we go on. So blood pressure is not just a simple thing. It is a continuum, and there are many types of blood pressure or phenotypes in blood pressure. So when somebody comes to the clinic, as you would see on your y-axis, the clinic blood pressure could be normal or raised. Whereas if we'll come to that later on, where if the patient's blood pressure could be measured as an ambulatory blood pressure. Patient's blood pressure could be measured while the patient is out of the shop, while the patient is engaging in normal day-to-day activities. The blood pressure could be normal or raised. Therefore, you get a 2x2 table as what you would see, and you see the simplest thing that would be there is there can be normal blood pressure both at clinic as well as the ambulatory or walking blood pressures, and it is called sustained normotension. Sometimes the patient could have a raised blood pressure at the clinic, but if you look at the blood pressure in ambulation or in normal life, it may be normal in the whole of 24 hours. So that is amounting to white coat hypertension. Sometimes the patient may come with normal blood pressure, normal instantaneous blood pressure at the clinic repeatedly, and may be masked or missed. But in fact, the patient may be having blood pressure which is elevated during the 24 hours. This is called masked hypertension or obscured hypertension. And of course, if it is evident, both at the clinic as well as in the walking phase, they could have sustained hypertension. So office blood pressure monitoring is what we are used to in a clinic, in a ward, in a hospital, or even in the field, where we check the blood pressure, making sure that the patient is set up like this with the arm cuff at the level of the heart, relaxing the arm, and then making sure that the cuff is 2/3 the length of the the arm, and seated comfortably in a resting position. But you also have the out of office blood pressure monitoring as well. As you know, your patients do come with blood pressure being monitored at home with their own devices, and this is called home-based blood pressure monitoring. And if you have the luxury, if you have the facility, then you have the option of doing ambulatory blood pressure monitoring or 24-hour blood pressure monitoring, which is able to detect the blood pressure point to point over a period of 24 hours or even more. So home blood pressure monitoring is what you see in the picture, where patients have a semi-automated blood pressure monitor and they keep a track of their blood pressures. One good thing is that it eliminates the white coat effect of the doctor, the white coat effect of the hospital environment, and it is shown that the home blood pressure monitoring values may be lower than the conventional office blood pressure monitoring that we usually measure. Definitely, there is some prediction of the cardiovascular morbidity and mortality with the value that we get in this home blood pressure monitor. The good thing about this is it enhances blood pressure control and adherence to medication. So the patient sees that his blood medication are working or not working and alert the doctor, okay, this is how my blood pressure is behaving in the usual way. Of course, it doesn't relieve the patient of apprehension-induced blood pressure, the white coat hypertension, which goes to levels of anxiety right throughout the day. So ambulatory blood pressure is what we are talking about here, where the patient, just like the Holter monitor, wears the blood pressure apparatus, automated blood pressure apparatus, which is pre-programmed day and night, 24 hours, maybe taking a break when the patient may be having a wash, etc., or changing clothes. So it is conducted so that the individual is able to go through their normal day-to-day activities. And the important thing is, which is not there in the home blood pressure monitoring, is that it provides us with data of variability. Blood pressure is a variable factor. It provides data as to how the blood pressure behaves, especially in the night when the patient is asleep. So we'll talk about nocturnal dipping later on. So studies have shown, and it is scientifically plausible, that it has a better prediction of cardiovascular morbidity and mortality. Definitely, it will help us to diagnose white coat hypertension and masked hypertension. This, you know, these are the cutoffs that are speaking of in European guidelines of hypertension, where we take as office blood pressure reading of equal or more than 140 of systolic and diastolic of more than 90 or equal to it. Whereas in ambulatory blood pressure monitoring, you have two steps, where you take a daytime mean or average of systolic of more than 135, while the nighttime systolic should be more than 120 to say this patient is having high blood pressure, hypertension. The ambulatory blood pressure readings for diastolic blood pressure, excuse me, give me one moment. Sorry, give me one moment. I need to connect to the power. I forgot. So the diastolic blood pressure readings are values of 85 or more for daytime or diurnal levels, or more than 70 millimeters of mercury for nocturnal values. So that's what we take as those two. You can forget about the rest of the other values. So how did this originate, this ambulatory blood pressure monitoring? So it was almost 40 years back that this was first brought into the medical scene in 83 by Perloff et al., where they said that there is a correlation between blood pressure and CV complications with regards to ambulatory blood pressure monitoring or 24-hour blood pressure monitoring. And you see, as per this graph, that how the prediction of cardiovascular endpoints, as in maybe an end point with a thrombotic event or even death, is related to the rise of the blood pressure. So on your left side, you see in small dots the values which are there for nighttime, and then you see on the middle you get the 24-hour behavior. This is the 24-hour behavior, and on the third line you see the one for daytime. So you see that it's an average of the nocturnal and the diurnal pattern of 24 hours blood pressure, where and how the prediction is. Compare that with the conventional office blood pressure, you see that it is at a lower level. So therefore, you seem to have a gap, a chasm between these two, which shows that the patients may be missed if you are not careful. So ambulatory blood pressure monitoring came into guidelines and into active use in 1999, and they have been taken as an important way of assessing those who are untreated when you have a suspicion that office-induced increased blood pressure is suspected. So you see that it took 17 years for this to come into practice, and it is now applaudable that this is now there to detect patients at carpet level. So this is the normal pattern of blood pressure behavior that you would see. Blood pressure behaves in a circadian variation, or they have a diurnal variation. During the day, there are fluctuations. And you see during nighttime in a normal person that the blood pressure goes down a bit. So in this graph, you see during daytime that the blood pressure is averaging about 128/78, and that is the systolic and the diastolic. And during the night time, it drops to values less than values of 110/62. So this is the normal pattern, or what we call as the nighttime dip, the nocturnal dip that is seen in normal persons. So the dipping status was first described by O'Brien and others in 1988. That was about 6 years after ambulatory blood pressure monitoring was described by us. And you see that in certain people, this nocturnal dipping is lost, right? So this is the dipper. The blue line is that of the dippers, and the one that is on as red is the non-dippers, where in fact, instead of having a dip or just plateauing, they may have a reversal. So here we see that the normal decrease of night blood pressure has been lost, and therefore it has been shown that those patients have a significant risk of cardiovascular events. So in fact, one study showed that non-dippers had a significantly higher stroke risk than dippers. So you get the hypertensive dippers, where these are the normal people, the normal dippers of hypertension, where throughout the day they have a persistently elevated blood pressure, right? So blood pressure of 147/93, then a mean, and then there is during nighttime there is a drop, plummeting of the blood pressure, and 211/66. So this is the normal dipping that you see, of course, in a patient with hypertension. There are, of course, in this graph, you see that there are instances where the blood pressure has just gone up instantaneously, maybe having a white coat effect. This is the one that we need to be careful more than the hypertensive dipper. Hypertensive dipper also is a problem, but hypertensive non-dipper is more problematic. Here you see that the blood pressure has been having a sort of a fluctuation without any trend, and the daytime blood pressure has been roughly about 210 over 135, and the nighttime blood pressure has been ranging a little bit the same, 205 by 130. So this is a non-dipper. So in fact, nighttime blood pressure is a far more worse, difficult risk factor in terms of cardiovascular events. And this study shows that the hazard ratio of 1 is there in controlled blood pressure as in daytime hypertension in this group, but in people whose blood pressure has not been picked up, masked, and they have nocturnal hypertension or non-dippers or reverse dippers, they have an increased risk. You see that the hazard ratio has gone up to 1.5. So that's where we need to be careful. So nocturnal dipping patterns can be non-dippers, where there will be no dipping compared to the daytime. They will have equal blood pressures, both daytime and nighttime. They can be reverse dippers, where in fact in the nighttime the blood pressure can go up compared to the daytime, which is a paradox. During nighttime the patient is more tormented. Or they can have an extreme dipping, the exaggeration of the normal response, or we call it extreme dipping. So non-dippers, or those who don't dip, have been shown to have be an independent risk factor for end organ damage, as it can go unidentified. Reverse dipping, or the blood pressure going up during night, has been shown to have worse outcomes with regards to kidney functions, as well as cardiovascular damages compared to the non-dippers. And what about our people who have the exaggerated normal response or extreme dipping? Well, in the night, the vital organs are underperfused. So again, they are at cardiovascular risk. So nighttime blood pressure is not measured routinely. And you see that home-based blood pressure monitoring is impractical, not pragmatic at all to measure the nighttime blood pressure, but ambulatory blood pressure monitoring solves this problem. Just like the dippers, you also get another set of people who are called those who have morning surgers, or we call them morning surgers. So you see, as per this diagram, there can be a dipper or a reverse dipper or a riser, as you would see. Now this is a reverse dipper where the blood pressure goes up during sleep, and this is a non-dipper or a person. Of course, sorry, this is a person with dipping, but in the morning, as one wakes up, there is a sudden shooting up of blood pressure or surge, and this is related to, again, worse outcomes. Why? It has been shown to increase afterload and increase arterial stiffness, increase left ventricular hypertrophy, and aid in worsening cardiac remodeling. It has also been shown to have increased risk of atherosclerosis and lead to thrombotic events. Furthermore, morning surges are associated with microalbuminuria. So you see that just like the non-dippers or the reverse dippers, the early morning surges are also people who we need to be careful of. So this is something that sums up all of this. So you see that daytime blood pressures in the shaded orange, golden shaded areas. And the ones sandwiched between those are the nocturnal ones. That's the nighttime blood pressure. And you see, although the blood pressures have been raised during daytime, this graph shows that there is nocturnal dipping demonstrated in this patient. So the hypertensive patient, but having nocturnal dipping. But you see that at the end of the sleep, as this person gets up, there is early morning surging of blood pressure, which is a thing that we cannot pick up in normal conventional blood pressure monitoring. What do you see there? That's the start of the ambulatory blood pressure monitoring. That's the place where the patient goes to the clinic and gets the ambulatory blood pressure monitor attached to him. And you see at that particular point within that first hour, the blood pressure has shot up so high. Why? The environment, seeing the patient, seeing the doctor. So that's white coat hypertension. So we are talking about white coat hypertension. Once a famous cardiologist who's working in Sri Lanka then said that he doesn't believe in white coat hypertension, but he believes in house coat hypertension, right? Maybe a joke, maybe about maybe patient when they are not only seeing the doctor, seeing the wife or some stressors at home that can lead into house coat hypertension. That's just a joke. But there is truly a thing called white coat hypertension, which was described by Flynert 2 years just after this description of the ambulatory blood pressures came into being. And these are patients whose blood pressure is elevated in medical environments, not necessarily the doctor, but even seeing the hospital board, even seeing the clinic, the walls, even seeing other patients, that can lead into white coat hypertension. So this is what we see as white coat hypertension. So on your extreme left, you see a shaded gray area. That is the place where ambulatory blood pressure monitoring has been started, as I mentioned in the previous graph. So you see, obviously, in such an environment, in a hospital environment, there is white coat hypertension. So it starts off with a very high blood pressure, and during the day, the blood pressure sort of comes to normalcy. And you again see that the patient has somewhat evidence nocturnal dipping seen. This is another thing. Just like white coat hypertension, there is also a white coat effect. So white coat hypertension is truly when the patient doesn't have hypertension, but in a clinical environment, the blood pressure shoots up. But how does it differ from white coat effect? The white coat effect is when somebody is truly a genuine hypertensive, and at the beginning of the clinic visit or at the beginning of the ambulatory blood pressure monitoring, you see that there are surges of blood pressure. So this is actually a subset of sustained hypertension where you see white coat effect as a hypertensive patient. So generally it's in a hospital clinic, clinician associated setting where there is stress involved. So in white coat hypertension, the target organ damage is usually mild or absent, even though the patient may be having a moderate to severe hypertension. Patient may be having a blood pressure of 180, 190. But you look carefully, there is no evidence of target organ damage, like there's no hypertensive heart disease, there is no ischemic heart disease, there is no kidney involvement, there is no retinopathy, there is no neurological manifestation. Of course, white coat hypertension is accompanied by tachycardia. That is because of the stress, because of the anxiety, the apprehension that the patient is having. Since this is a stress-related event, there is poor response to antihypertensives. And what happens when the patient, just like our patient who died, Mr. A, at the beginning, when the patient is started on antihypertensive, lo and behold, the blood pressure shoots down, plummets, and then the patient can have hypotensive events and lead from pre-syncope, syncope, and even unto death. Usually these are seen in females and old people who are generally having stress and who have a personality which is towards being stressed out. So white coat hypertension has a high risk of cardiovascular problems as well as all-cause mortality. So if even though you do not start blood pressure medication initially, you need to remember you can't just wash off your hands and leave the patient alone. You need to re-evaluate the patient. Why? Those who have white coat hypertension someday have the risk of developing sustained hypertension. In fact, it is 2 times the risk than a normotensive patient. So don't forget about them. You need to arrange follow-up. These are survival curves of patients who have low risk and high risk factors. Low risk as in maybe up to 2 risk factors, high risk meaning more than 3 factors, including diabetes, smoking, male sex, dyslipidemia, all those things that we know of ischemic heart disease. And you see in a person with low risk setting, the incidence of cardiovascular events is not so great, whereas somebody with high risk, you see that there is a vast difference. Therefore, you need to address people with high risk white coat hypertension in targeting their possible future events. Although the current evidence is not in favor or of against blood pressure lowering in patients with white coat hypertension, ambulatory blood pressure monitoring is shown to confirm white coat hypertension, helping us to avoid unnecessary treatment, as in our first patient, patient A, who died of a ischemic stroke. But then again, somebody who has white coat hypertension needs to be followed up in the long setting to see whether they shift over to genuine hypertension. We move on to masked hypertension. Masked hypertension is characterized by a normal blood pressure, which is in the clinic, in the office, but they have sustained blood pressure rise outside the clinic. So it has been obscured for unknown reasons at the clinic. But if you look at the 24-hour curve, you see that the blood pressure has been higher than what was there at the time of the clinic visit. So these are seen in men. The white coat hypertension was seen in women. This is seen usually in men, and they have a family history of hypertension. So just when somebody with a strong family history of hypertension comes and his blood pressure is normal, you need to think about whether we are dealing with masked hypertension. Sometimes it may be a transiently elevated hypertension. Patient may come with a high blood pressure reading, and then you tell the patient, relax, now wait, sit down and wait. And then in about 10 minutes time, you check the blood pressure. The initial blood pressure would have been 200 by 100. And suddenly when you check again, the blood pressure has come down to 120 over 80. You need to question yourself, is this a masked hypertension? Certainly people who are obese, persons who engage in these activities like smoking, alcohol, and heavy caffeine use, they are at risk. So you need to look into those people who are with these problems, and in particular, those who have high cardiovascular risk. So if I may deviate, how do you check for cardiovascular risk? You can use the normograms that are available, especially the ones that are there by the WHO, which are there for the region, for the Southeast Asian region, region B, where you can, depending on the sex, the smoker or non-smoker, and the level of blood pressure and the level of sugar and hypertension. There are various normograms, and then you can find the risk. So if there's somebody with high cardiovascular risk, you need to think of addressing them. Diabetics, definitely. Patients who have chronic kidney disease, but who don't seem to have hypertension when you check them, you need to worry whether they have masked hypertension. Target organ damage, as I mentioned before. So what are the implications? They have worse implication than consistently normotensive patients. So they have an increases from major cardiovascular event, hypertension, to develop in 10 years time, and even developing diabetes and impaired fasting glucose and progression to cardiovascular disease. So you see that this is showing the percentage of those with masked hypertension. You see in normal office normotensive patients, and how it is there with office pre-hypertensive patients. So this is something that you need to observe. These are forest plots of cardiovascular events that you see as one progress from normotension to pre-hypertension, and from normotension with masked hypertension or to pre-hypertension with masked hypertension. You see that the cardiovascular events go up thereafter. So how do you unmask the masked hypertension? So when you check the patient at the clinic visit, and if the patient is having a blood pressure less than 120/80 without any risk factors or any of the diseases that we mentioned, you can think, okay, this is a definitely normotensive patient. You can just observe the patient maybe 6 monthly or annually. If the patient is having a pre-hypertensive level of 120/140 or 80/90 in diastolic, you need to question, is this somebody who may be having masked hypertension? So that's when you offer ambulatory blood pressure monitoring. So ambulatory blood pressure monitoring will be able to differentiate the normotensive from masked hypertension. Certainly a person who is having more than 140/90, then that person would deem into being a sustained hypertensive or a white coat hypertensive. So as we discussed, masked hypertension is associated with increased risk of cardiovascular events. So the easiest way or the most efficient way of unraveling the masked hypertension is to use ambulatory blood pressure monitoring, and helps us to initiate early intensive treatment. So you start, you think about ambulatory blood pressure monitoring in these people for white coat hypertension when there is stage 1 hypertension, or there's variability of blood pressure monitoring pressures in the clinic, or if there is evidence of high blood pressure without any target organ damage. That's the place when you think about white coat hypertension and you need to target them. You need to think about masked hypertension when there is raised blood pressure, right? And even a pre-hypertensive, or in any patient who has normal blood pressure with evidence of target organ damage, or any patient with high risk like diabetes, chronic kidney disease, having sleep apnea, endocrinological problems, etc. So that's how you deal. So out of hours blood pressure monitoring is used as home blood pressure or 24-hour blood pressure monitoring, and it is shown that it is more reproducible. It can be shown to have similar findings if it is done on several days repeatedly. And it is closely associated with hypertension, induced organ damage, and increased risk of cardiovascular events and to identify white coat and masked hypertension. In another sphere, ambulatory blood pressure monitoring or even home blood pressure monitoring can be used by validated devices for those who are pregnant or having preeclampsia to differentiate again whether they are really having high blood pressure or is it because of white coat hypertension, etc. So in 2008, the Europeans put out this where they said if there is normal blood pressure monitoring at the clinic, you can repeat the blood pressure at least every 5 years, I would say even annually. Normal blood pressure with a pre-hypertensive level of maybe 120 or 130 and 80 by 94, you need to check blood pressure at more regularly. If the blood pressure is pre-hypertensive, like 130 over 100 to 130 to 140 or 80, consider masked hypertension. Is my patient having masked hypertension? So then what you could do is you can check the blood pressure at least annually, or you could offer ambulatory blood pressure monitoring, which will show you some evidence whether the patient is having hypertension repeated, persistent. If the blood pressure is more than 140 over 90, definitely you need to confirm the diagnosis. So you can do repeated visits at the clinic to see whether the patient is having genuine blood pressure, or you can do out of office blood pressure monitoring like ambulatory blood pressure. When would you think about that? When there is absence of target organ damage, and if you are thinking that the patient is a person who is highly strung, a stressful person, elderly person who is most likely a female. So those are the indications for ambulatory blood pressure monitoring. So when would you think about ambulatory blood pressure monitoring rather than home-based blood pressure monitoring? So it is shown that it is more logistical and economically when it is feasible, and it is when you have to think about detecting the nocturnal blood pressure values and the dipping status, as I showed you in the graphs. So when you suspect somebody to have nocturnal hypertension and conditions like sleep apnea, CKD, diabetes, endocrinological problems, or autonomic dysfunction, that's when you have to think about it. So you see the rate of masked hypertension in diabetes, you see that the increased prevalence of masked hypertension occurs with diabetes. So on your left, you see the diabetics who are treated and untreated, and on the left, right, you see the non-diabetics with masked hypertension. So masked hypertension in diabetes is significantly shown to have high incidence of cardiovascular events, and you need to therefore proactively look for masked hypertension in patients with diabetes. So diabetes and chronic kidney disease have higher prevalence of masked hypertension. So you need to think about the recommendations of ambulatory blood pressure monitoring over office or home blood pressure monitoring to diagnose such patients. What about resistant blood pressure or hypertension? So resistant hypertension is when you think about blood hypertension that does not respond well to aggressive medical treatment. Of course, those patients should be on 3 medications of various classes, different classes, and at maximal tolerated doses. So they are yet with all these, with multiple classes at maximum tolerated dose, they fail to achieve the target blood pressure. So what are the risk factors for resistant hypertension? They could be diabetics, older people, people who have kidney problems, and sleep apnea. That's why all these risk factors of resistant hypertension were concerned in masked hypertension in detection. So with that, you need to differentiate pseudo-resistance of due to poor adherence or white coat effect or poor blood pressure measurement technique, etc. So how can you do that? You can use the ambulatory blood pressure monitoring, which will aid to differentiate all of these. The white coat hypertension, the non-adherence, poor compliance, also the poor choice in antihypertensives. Don't forget those who are abusing medication, substances, recreational drugs. It may be nasal decongestants, or even traditional or medication, Ayurvedic, non-Ayurvedic, traditional medication. You need to consider about those. And also the secondary hypertensives, which is due to most likely ongoing endocrinological problems. So for an isolated clinic hypertension, if there is persistent high blood pressure, you need to look for target organ damage. If there is target organ damage in a person with isolated hypertension, you commence on treatment. There's no target organ damage, you can offer home blood pressure monitoring, or even better, the 24-hour blood pressure monitoring, which will confirm whether the patient is having genuine hypertension. Therefore, you start treatment. If 24-hour blood pressure monitoring does not show any hypertensive changes related to target organ damage, then you monitor at clinic levels regularly, and don't forget the patient, as they can go into genuine hypertension later on. For masked hypertension, if there is persistently normal blood pressures with target organ damage, you can offer the 24-hour monitoring, and if it is high, you start treatment. And again, you can use it to monitor. So for treatment, so what you do when you look for, when you check ambulatory blood pressure, if the office blood pressure is low and the ambulatory blood pressure is high, then that puts you into either controlled hypertension or masked hypertension, as we discussed. If the ambulatory blood pressure is low with office blood pressure being high, then it goes towards the white coat hypertension, or it could be true hypertension. Therefore, you need to adjust yourself, and you need to think about resistant hypertension if there is persistent hypertension there in those with positive ambulatory blood pressure monitoring. So advantages of blood pressure monitoring is that we can identify white coat hypertension and masked hypertension, and it's a strong prognostic evidence provider. We have the luxury of looking at the nighttime recordings and the real life settings, day in, day out, the real time values. We can prognosticate and find out the blood pressure phenotypes, the 4 phenotypes that we mentioned, and we can get a lot of information, including the variability, the morning surges, the dipping, the nocturnal dipping, the reverse dippers, etc. So, of course, disadvantages being it is uncomfortable because the patient has to use it continuously for 24 hours, and there will be cuffing and decuffing. So you need to educate the patient on the compliance of using the device over that period, and proper installation is taken ahead. Of course, if facilities are not available very clearly, it may be expensive and sometimes limited in availability. So that's a drawback of ambulatory blood pressure monitoring. If there is facility, if there is a chance, if it's affordable for the patient, cost effectiveness, then you need to think about ambulatory blood pressure. So I end with this. I started with something from humanities. I end with something again from humanities. So practice of medicine is an art, not a trade. It's a calling, not a business, where your heart, we are talking about the World Heart Day. I'm talking here about the deeper heart. William Osler is talking about the deeper heart. Will have to be exercised equally with your head, the heart and the head. Thank you so much.
Thank you very much, Dr. Shehan Silva. I think it was a fantastic session. I think you started with the quotes from humanities, talking about the heart and or the deeper heart. And I'm glad that I was part of this event on World Heart Day, where blood pressure is touted to be the most important cardiovascular risk factor, most important risk factor for stroke, and also one of the most important risk factors for other coronary heart diseases. So it was great to have you on this platform on this World Heart Day. And on the last point that you mentioned, sir, I just want to inform the audience that Zydus is offering ABPM device services in several regions across Sri Lanka, which I will briefly talk about later. For now, sir, once again, I'd like to thank you for this very interesting session where you discussed the different phenotypes of hypertension, particularly the white coat and the masked hypertension, and also shared some interesting algorithms to unmask the masked hypertension and managing hypertension with ambulatory blood pressure monitoring. There are a couple of questions from the audience. So, sir, with your permission, I'll proceed with those. So the first question is very interesting. And while we have spoken about the patients in office or patients at home, the question, although posted anonymously, the question is, what will be the pattern for hospitalized patients or immobilized patients?
Hospitalization, immobilization.
Yes, sir.
There is some echo.
So one of your mics needs to be muted. Yeah, thank you.
Okay, right. So what will be the pattern of hospitalized patients or immobilized patients? Well, I am not too sure about that. If you are thinking about hospitalized patients having ambulatory blood pressure, then of course it's not going to be of use, because the whole purpose of ambulatory blood pressure monitoring is to see how the patient is behaving in his own environment, in a normal day-to-day environment. We are not, I mean, we have to consider ourselves, we are not always in our sick role. So how does one engage in day-to-day activities from the time they start, from they get up, from they use the washroom, they eat, they go for their work, they come back, they do their household chores, and get themselves entertained, and they go to sleep. So that is the normal thing. Of course, in a hospitalized environment, that is going to be an artificial environment, or as I would say, it is a it's not going to be the purpose of ambulatory blood pressure. So I haven't really looked into these hospitalized patients, but I don't think it's useful, because the patient has to be ambulant or be a normal person. Immobilized patients, well, yes, that may be a good thing to read up on. Again, immobilized patients, day to day, although they may be confined to one place, they may be having a routine. So there may be a place for looking into immobilized patients. Yes, that's true. But I'm not sure about the data.
Right. So then, no, I think that's a very interesting point to look at. What does the medical literature say about such patients? But moving on to the subject of white coat hypertension, and you did briefly allude to that in your presentation, that white coat hypertension does increase the risk of cardiovascular events. So this is actually a gray area where the guidelines are not really clear on whether white coat hypertension should be treated or not. What is your take on this matter?
So the take-home message is that white coat hypertension is actually an artifact. It is an artifact of high blood pressure reading at the clinic. But you need to look into whether the patient is having target organ damage. If there is target organ damage, definitely you need to start on your treatment. Other than target organ damage, you need to look into the possibilities of risk factors. The other risk factors, as I mentioned, the WHO, the risk scoring or any other scoring, in fact, will tell you the cardiovascular mortality, morbidity, and the mortality, the 10-year risk. And if it is definitely significantly high, then you need to consider starting treatment. So patients who are having low risks of cardiovascular mortality, you may not start immediately. Even the same with higher risk patients, but you need to keep on monitoring them. While the guideline says if the facilities are there, you need to check 3 monthly. You need to do 3 monthly ambulatory blood pressure monitoring, but it may not be practical in a low resource setting. So, but at least if we can be on the watch, okay, this patient may be having a higher risk and definitely move on to being a real genuine hypertensive. That is a possibility. The other thing is, which is actually a paradox, what has been shown, although white coat hypertension is a situation where there is detected high blood pressure at clinic levels, you need to think about the possibility of them developing into genuine hypertension later on in life. So that is actually shown to be double than that of a normal patient with normal blood pressure. So people who have white coat hypertension in the future, they have a risk of developing genuine hypertension twice the amount as that of a normal normotensive patient.
So another question we have received is about a particular phenotype of blood pressure. What is the reverse dipping of blood pressure?
Yeah, so reverse dipping of blood pressure is actually the mirror image of a dipper. So instead of dipping, when you as you understand physiologically, the blood pressure should drop down during sleep. But instead of just without dropping down, if the patient is having a flat line, that is non-dipping, but it can be the reverse, where instead of dipping, it can go up during. So if there is, in fact, higher blood pressure readings during night, that is called reverse dipping. So in fact, that is associated with greater cardiovascular adverse events.
Right. And talking about phenotypes, I just restrict myself to the last question here to respect everybody's time. We were talking about phenotypes, and so basically, how could antihypertensive therapy be optimized for different hypertension phenotypes? Now, given that ABPM can help to identify different phenotypes, then how could we translate this into an optimal antihypertensive therapy for patients?
So definitely, if somebody is having masked hypertension, then you need to go on the conventional antihypertensives that you would use as per guidelines, the angiotensin converting enzyme inhibitors or angiotensin receptor blocker drugs, ARBs, ACIs, or go into calcium channel blockers or even diuretics. And then you go up as a combination. You optimize the drugs and then you go up. So it's the same way as you would manage a patient as per the guidelines that are there, the JNC 8 guidelines. So the management is the same. Pharmacologically, the management is the same. Of course, don't forget the non-pharmacological management about the diet, about salt restriction, about lifestyle changes, exercise, and also control of stressful events, etc.
Right. Thank you very much, sir. So with that, I'd like to conclude the Q&A session. And for the benefit of the audience, as I said earlier, that Zydus has been providing these ABPM services. We call it ABPM on call. So these kind of services are available in several regions across Sri Lanka, and I will show the regions in the next slide. But what specifically we do, or how we operate, or how we provide these services is basically through the doctors to the patients. And basically we have our team whom we refer to as the single points of contact, that is SPOC. Basically they are Zydus medical representatives who brief the doctors in their regions about the availability of this facility, so that whenever the doctor identifies a patient, and doctor can ask the person to go to the patient and explain the details about the BPM, and also help the patient to install the device, or it can also be done within the doctor's clinic if appropriate. And the patient then has to follow the instructions. For any concern, the patient can call the person, and if required. So usually this is a 24-hour recording, after which our person will retrieve the device and download the data from the device and provides the result of the copy back to you. So this is how we conduct this. It's a very simple flow in which just it starts with the doctor calling the Zydus medical rep to provide this ABPM facility, and it concludes with the rep providing the results of the patient to the doctor. Basically, so far we have trained the staff, and I'm happy to share that 400 plus patients have benefited across 13 regions. So we have ABPM device available in all these regions which are mentioned here, from Kalutara to Negombo, Kandy, of course Colombo, Karunagala, Ratnapura, Anuradhapura, Trinco, Gale, Jaffna, Kelania, Nugegoda, and Matara. So these are all the regions where these ABPM device facilities are available. You may please get in touch with any rep who is promoting either Irbeside, Losaka, or Tel OD. These are the Zydus ARB brands available in Sri Lanka, and all these reps have been trained to help the doctors install ABPM for their patients whenever required. So again, on this World Heart Day, I thank you wholeheartedly for joining this webinar, and do look for patients who would be eligible for ABPM, and call our reps to support your patients with this activity. Once again, I thank the audience for joining this event this evening, and of course, a big thanks to Dr. Shehan Silva for not only delivering the talk, but also answering the questions for the audience. And I hope, sir, we will come back to you if there are more questions from the audience received later on. And we hope that you will be able to help them understand and quell their disbeliefs or wrong beliefs about ABPM as required.
Thank you. Thank you so much.
Thank you. Thank you, everyone, and have a good evening.